Okay, we can start this session. The first student is Camille Jerry-Jules, and supervisor is Professor Chiaravallotti Agostino. The work is about the 18F-DOPA CT, SUV-derived insights and volumetric parameters correlation in patients with primary brain tumors. Keep calm.
Okay, thank you. Okay. Good afternoon, everybody. My name is Camille Jerry-Jules. My thesis is done under the supervision of my tutor, Chiaravallotti, and my co-tutor, Maya Uchi. I'll start with the introduction. My thesis is an observational study, empirical research. About the introduction, I speak about okay. No. Okay. Thank you. Okay. About the introduction, I will speak about the use, the contribution, and mechanism of 18F-DOPA with PET-CT for primary brain tumor in diagnostic imaging. 18F-DOPA PET-CT is useful in management of glioma, assessment of tumor location, size, biological activity, useful to more precisely delineate tumor margin, improving targeting of biopsy and radiotherapy, improving surgical planning, useful to distinguish tumor recurrence for non-specific post-treatment scar tissue, to predict the prognosis of low-grade glioma and to monitor metabolic response after treatment. About the mechanism of 18F-DOPA PET is the F-DOPA PET enter the cancer cells to offer L-type amino acid transporter 1 and 2, and is decarboxylated. With the formation of 18F-dopamine transported in vesicle. Vesicle that is the place of the biggest protein synthesis for prominent uptake of radiopharmaceutical. In this image, there is uptake of 18F-DOPA PET in the basal ganglia and tumor boundaries. Let's go to the, okay, in this image there is an example of pediatric brain tumor. In the image of the left side, there is an example of in a patient of with astrocytoma. And the other image on the right side is the example of a patient with glioma 2. Let's go to the objective. About the objective, I want to speak about how to calculate the 18F-DOPA PET-CT standard uptake value, the indicator, and correlation with volume parameter. Standard uptake value is calculated to assess the absorption of radiopharmaceutical by cancer and PET-CT analysis. Standard uptake value is calculated as tissue activity ratio by to a given time divided by dose injection and by body weight. Dose injection in kilobecquerel and body weight in kilogram. 18F-DOPA PET enter in variety of metabolic pathway. Example of synthesis of peptide, purine, pyrimidine, hormone, and acting as a methyl group donor. Absorption of cancer is evaluated by SUV index as SUV-max ratio, SUV-min and SUV-min ratio. About the volume parameter, there is a metabolic tumor volume and total lesion of DOPA activity. total lesion glycolysis for 18 F-DOPA imaging or a potential support during the prognosis stage in the assessment of primary brain tumor. Using 18 F-DOPA PET CT, severe derivative indice, dopaminergic tumor volume, total F-DOPA activity, total lesion F-DOPA activity, with no clear correlation with the volume absorption parameter. In this case, in this image, there is a spatial machine with severe derivative indice of F-DOPA with a relative cerebral blood volume. Let's go to the difference between high grade and low grade tumor, an uptake ratio tumor to normal tissue. In this part, I will speak about the difference on time activity curve, sensitivity, specificity, visual analysis based on 4-point scale, and recommendation. Kinetic uptake of 18 F-DOPA PET revealed the difference in time activity curve that at grade tumor show an initial maximum, followed by a sharp decline. And low grade tumor show a slow decline curve. Different diagnosis made with the semi-quantitative analysis of the standard maximum uptake value, that is the submax, which is the parameter of radiotracer uptake. The submax is the parameter of the radiotracer uptake in tumor. To better distinguish low grade and high grade tumor, a submax of 2.72 is optional. Addition of the semi-quantitative analysis for 18 F-DOPA determination ratio, tumor striatal ratio, tumor normal wet matter ratio, and tumor contralateral normal bone tissue ratio, improved specificity. About the specificity and sensitivity, when tumor striatal ratio sensitivity was 0.75, the maximum sensitivity was 100%, and the specificity was 86%. But when a tumor striatal ratio was 1, the sensitivity was slightly reduced to 92%. And the specificity was 95%. Patient with positive test has for 2.2 times shorter of median overall survival than patient with negative test. As you can see now, about the 4-point visual scale, with the score 0, there is no lesion uptake. In score 1, the background uptake is inferior to lesion uptake and is inferior to striatum uptake. With the score 2, lesion uptake is equal to striatum uptake. With the score 3, lesion uptake is superior to striatum uptake. About the material and method. I speak firstly with the material. About the material, we choose 133 patients that underwent 18 F-DOPA imaging for primary brain tumor to confirm the increasing importance of 18 F-DOPA parameter. Standard uptake derivative index is calculated to take in account a quarter of occipital lobe of standard volume of interest of 1.5 cm per 1.5 cm per 1.5 cm is selected to generate the tumor standard uptake ratio and compared to the volume parameter. For the reconstruction of PET image or the red subset exploitation maximization, abbreviated or SEM, with 4 iterations to any subset and standard technique of 2 model of 256 per 256 matrix for the acquisition of the image. All this part is all for the material. Also the low red CT scan for attenuation correction with the parameter for 40 milliampere and is 120 kilovolt. Performed before PET acquisition. All patients injected intravenously by 4 megabecquerel per kilogram of F-DOPA or 18 F-DOPA injected by 500 ml of chlorine sodium. About the method, 18 F-DOPA PET standard uptake, and these are assessed by using different dedicated workstation. Patients with gamma recurrence progression can be detected by the static and dynamic 18 F-DOPA PET parameter. According to the result of the examination, both standard uptake value max and standard uptake value max ratio correlate with the dopaminergic tumor volume and total lesion F-DOPA activity. They are associated with an improved evaluation and health uptake of radiopharmaceutical. About the result of the examination on the evaluation of 18 F-DOPA PET survey, the evidence correlation with the volumetric parameter, I will speak about the univariate analysis and correlation value with submax ratio to with DTV and TLDA. Regression model applied to univariate analysis that is shown here, where submax is positively correlated with dopaminergic tumor volume, with a beta equal to 0.42 and P 0.007. Also, submax ratio is positively correlated with the dopaminergic tumor volume, with beta equal to 0.80 and P equal to 0.011. Also, there is a correlation of submax and submax ratio with total lesion F-DOPA activity. Our results show that PET-CT F-DOPA, the 18 F-DOPA volume parameter, are easy to access the primary brain tumor with high submax and high submax ratio, and support the new role of volume parameter in interpretation. About the discussion and conclusion, for the conclusion, for the discussion before. In the previous paper, 2.5 standard uptake value threshold used for metabolic tumor volume and total lesion F-DOPA calculation. In other study, metabolic tumor volume obtained by 3D automated controlling process with using threshold corresponding to the standard uptake value mean of contralateral striatum. According to previous publication, all standard uptake value the evidence studied, including the standard uptake value max, accurately distinguish low grade and high grade glioma and correlate most closely the index of from standard uptake value mean, tumor normal brain ratio, and standard uptake value mean tumor striatal ratio. In this study, ratio of tumor uptake to normal tissue uptake by dividing the tumor standard uptake value by contralateral centrum. Sieve striatal standard uptake value has been generated. Maximum standard uptake value ratio calculated with occipital uptake was also associated with good prognosis. In the examination, we have chosen for the evaluation of volume parameter on the occipital lobe. With good prognosis, correlated with both progression-free survival and overall survival. To conclude, more multi-center study or larger sample are necessary to arrive at a proper classification of patients with primary brain cancer. Focus of PET-CT study. That is the limit of this study. That is need to do more study because standard uptake value and volumetric parameter are novel new parameter in the diagnostic of primary brain tumor with 18 FDOPA PET. But to date, we consider PET-CT as available tool that can help in image analysis. Our result confirm the importance for calculating a standard uptake of value derived in this volumetric acquisition parameter in PET-CT evaluation. Surprisingly, the best correlation between Suvmax and Suvmax ratio and total lesion a total lesion of the activity is described, as shown before with the graph. This graph. The result support the interest of 18 FDOPA volumetric index. Thank you so much to everyone for your attention.
Thank you, Jerry Jules. It's just a comment to your discussion, and thank you for your discussion. I mean, this is the first published the paper on this topic, since we know that tumor volume is related to a bad prognosis in primary brain tumor. This is what we know from MRI. But actually, we are able to demonstrate that also metabolic parameters are related to a worse prognosis in these patients. So this work actually assess that there is a relationship between the uptake indexes that we have in nuclear medicine. So these indexes can be used for as prognostic factors in the patients with primary brain tumor. So I think that you addressed all the points of this study, and so thank you for your presentation.
Okay, thank you.
Okay, Dave, it's time. The second student is Delva Dave. The work of Dave is about treatments in prostate cancer. And in this work, Dave presents different therapeutic treatments for prostate cancer. Usually, treatment options are radiotherapy, chemotherapy, or monotherapy, and surgery. Please, you can start.
Good afternoon, everyone. I thank you for coming in my final dissertation discussion. And today I will discuss about the new treatment of prostate cancer. First of all, let's have an overview on the prostate. The prostate, it's a small gland that it's a small gland in man that help in the formation, in the production of the semen. It is located just below the bladder, in front of the rectum, and wraps in around the urethra. The prostatic adenocarcinoma is defined by an uncontrolled proliferation of the gland's epithelial cells that expand anarchically from a malignant tumor. This disease has a slow progression and sometimes has no clinical symptom and sign. Prostate cancer is the first cancer diagnosing man. Is the reason why we're witnessing an increased incidence of improvement of diagnosis and improvement in treatment. For the diagnosis tool, the first is the PSA, the prostatic specific antigen, which is a laboratory test performed in blood. And we have also to assess the urinary function to see whether likely it is in the prostate, and the digital rectal examination is important because it allows to show the prostate by your hand, fingering the patient, of course. And we have also to perform the differential diagnosis, which allows to see the material, the leukocytoria, and urinary infection. Once we're pending for a diagnosis, we have to, of course, to perform a biopsy, which is the histological examination. In order to assign a risk to the treatment and to decide on the treatment strategy, if any, there is some parameters that to take into consideration. The first one is the PSA value, the Gleason score, which represent all the cancer cells are proliferated, and also the tumor extension assessed by means of the digital rectal examination. The treatment of prostate cancer, as any cancer, depend on staging. We can go through active surveillance from very low risk patient through surgery or radiation beam therapy for very high risk patient. In between, we have a choice in the focal treatment, which the first one is the focal laser therapy, the first treatment that I choose to talk about. The focal laser ablation uses a laser to kill the tumor cells. Photodynamic therapy, laser interstitial therapy, or type of focal laser ablation. The photodynamic therapy uses a visible light to a specific wavelength to activate photosynthesizing drug. And the most used is the hematoporphyrin, and the laser interstitial thermal therapy is also a kind of laser therapy that uses laser filter through needles to create tissue necrosis. Here as you can see in those images, the first tree shows the apex of the tumor and also the contrast enhancement, and the last tree shows how the prostate disappears. The second treatment is the agent therapy. The agent therapy uses carbon ion therapy and also proton therapy instead of photon therapy. And for the carbon ion therapy, in Italy there is the CNO, il Centro Nazionale di Radiotherapia Oncologica. It's a center that treats the prostate cancer with carbon ion therapy with a range from 60 gray delivered in 4 fractions of 4 grays. And for the proton therapy, the most important thing to know is that with the proton therapy, we can have a better focal lead deliver over the prostate and without sparing the normal tissue. In this scheme, we notice also other agent therapy choose the proton therapy to have a specific to enter to the death of the cancer, of the prostate cancer. Here is two identical cross-sectional computer tomography that make the comparison between the photon and the proton therapy. We can see that in the first image, it's the case of the photon therapy. The distribution is also in the periphery, and in the second image, the B, we can see that the distribution is more specific. And for last, it's the cryotherapy, which is a form of freezing of the tumor cells by introducing a needle through the prostate cancer and trying to obtain a temperature of minus 40 degrees. And it's also one of the less invasive between all the choices I made for discuss about. And also, as you can see in this image, it's also the first three also shows the progression of the prostate cancer and also the contrast enhancement. And the last one shows how the cancer also disappear. To conclude, the prostate cancer treatment depends greatly on the stage of the disease, varying from the watchful attention to surgery and systemic therapies. For localized tumor, focal therapy represents a strategy to successfully destroy areas of cancer, sparing most prostate normal tissue and minimize side effects. Many presented strategies are available only in clinical trial setting. Therefore, long-term results are still awaited. Je dis tout le monde qui t'a regardé merci et j'espère que nous fiers de moi. And in my language, I just say thank you to everyone for their attention. Thank you so much.
Thank you, Dave. If I can just spend a couple of words on the student, my student. Yesterday he sent me an email. Well, he wrote, "I'm ready and I rehearsed my presentation and I hope you will be proud of me." Well, I am. And I'm proud of all the students here. They are the first to discuss and defend their thesis, and really good luck for your future. Well, Dave has been always very interested in oncology. I'm a kind of outsider here because I teach oncology. And he's been always very interested and curious. I think curiosity in Dave is the main feature that has driven his study so far. When he asked me to be his supervisor in this type of thesis, I was very happy, of course, and interested in that, as David said, prostate cancer treatment varies greatly. That can go from a watchful attention, which is a problem also for the physician to explain to the patient that it's better for him to live with his prostate cancer. And of course, for the more aggressive forms, there are more aggressive treatment. In between, what we really need are focal therapies, sparing normal tissue and preserving the man function and avoiding all side effects. So thank you, Dave. It's been really nice to have you as a student.
Okay, it's your time, Joseph. It's not happy. Okay, with Joseph Onkpadin, we have done our work about the system of dose modulation in CT, because our recent European law, the Euratom 2013, regulates the reorganization of the legislation concerning the radiation protection of the workers and the population. For these reasons, the CT is the most popular test. And with Joseph, we have done the system of dose modulation in CT. Go, Joseph.
The step of CT imaging production. Okay. First of all, I want to begin by explaining the step of CT imaging production. The infrared tube produces ionizing radiation, which passes through the patient on the part of the body needed. This radiation reaches the detector, which produces electrical signal. The electrical signal is converted by the ADV, analog to digital converter, which converts the electrical signal into digital data useful for the computer for image reconstruction and image display. Now, I want to explain some CT dose reduction strategies. First, we have milliampere adjustment. A small dose is required for small bodies, and a large dose is required for larger bodies. While some studies use the patient's weight to alter milliampere second, others prefer to use the patient's diameter to establish the best milliampere second setting. Both approaches have proven to be effective. Secondly, we have automatic tube current modulation. Manufacturers have now supplied consumers with another way to reduce patient dose. Some systems have a filter that adjusts tube current based on the patient's expected attenuation at a specific area. Scout image in both the anteroposterior and the lateral projection, as well as the slices, are used to make the estimates. The milliampere will be designed to change by location throughout the length of the patient based on these views. The specifics of the option differ depending on the manufacturers. Third, we have a kilovoltage increasing avoidance. The radiation dose and penetration of infrared through the body increase as the infrared tube potential is increased. Increase in voltage above 120 kilovoltage should be avoided in general, except when imaging obese patients. To compensate for this increased dose, an increase in kilovoltage could be followed with a decrease in tube current. Fourth, we have pitch increasing. Increasing the pitch of the CT examination is another effective way to reduce radiation dose while using helical scanning. Researchers discovered that changing the pitch from 1 to 1.5 reduced the dose by 33% without sacrificing diagnostic information. Fifth, we have the thin slices use limitation. When a significant number of thin contiguous CT slices are used to scan the same anatomy, the patient receives 30 to 50% more radiation than when fewer thicker slices are used. Although avoiding thin slices is not always practicable, technologists and radiologists should be aware of the effect. Since we have the repeat scan limitation, repeat scan of the location have a cumulative effect. Therefore, duplicate or multi-phase studies should only be done when clinically needed. Despite the fact that multiphasic investigations are clearly indicated for evaluating liver disorder, they should not be performed in all cases. At last, I want to talk about the Iterative Reconstruction, which is a newer approach in image reconstruction that has just been introduced for use in CT, computed tomography image reconstruction, and can reduce the dose by up to 50% when compared to typical filtered back projection method. In this slide, I want to summarize the CT reduction strategies. First of all, we have the alternative modalities which must be considered. We choose the appropriate technical parameters, the region coverage limitation, the reduction of the use of multi-phase examination, milliampere second based on size adjustment, milliampere based on region adjustment, milliampere based on clinical indication adjustment. Increase the pitch. Thin slices use limitation. Use the new equipment option that automatically adjusts those during examination. Patient shielding is very important in CT because we use ionizing radiation. Here we have some device we use in CT. First of all, we have a General Electric which provides high quality diagnostic treatment by using low radiation dose, while Toshiba uses sure exposure, automatic exposure control to select the target image standard deviation from a drop-down list. So the technologists can modify the protocol in order to reduce radiation dose for the patient. Philips gives a low dose and a high image quality, but Siemens gives more detail and reduced streak artifacts. The computed tomography, to conclude, scan is a useful imaging tool where it is positively indicated. But CT is followed with a high radiation dose, so there is some danger involved. The risk of CT is greatly surpassed by the possible benefit in circumstances. So in CT we have more radiation, but the benefit we have is more, if we want to evaluate, it is more than the side effect. So CT is indicated. So thank you for following me. Grazie mille. Eshon Mibasi.
Good, Joseph. I don't have any question for you, because I think in this work we present all technical solution for the reduction of the dose, and we compared the general manufacturers about CT scan. Okay, good work.
Thank you, Prof.
Thank you. Okay, it's the time for Ledoux. Please sit down. Okay, with Ledoux, present a work about the techniques of execution in angiographic acquisition with the CT system. The supervisor is Professor Di Lascio Antonio, and the aim of this work is to explore and analyze the importance of computed tomography in the study of vessels, illustrating all the operational aspects connected with the professional exercise of the activity of the medical radiation technician. Okay, you can start.
Okay, good evening, everyone. My name is Jenna Ledoux, and it's a pleasure for me to share with you my presentation, which is my thesis, which is titled Techniques of Execution in Angiographic Acquisition with CT System. Let's start with this first question. What is CT scan? It is a non-invasive technique that provides axial but also coronal and sagittal images of the body by distinguishing the various organs and also tissues based on their density through a collimated X-ray beam that crosses the body. This is a schematic view of the function of the tube. Here we can see how the tube is rotated around the patient in order to give us the axial images that we acquired. Which are the components of the CT scan? The computed tomography is composed by the gantry, in which we find the X-ray tube, the slip rings, and also the detectors. And then we have the patient table on which the patient is lying, and we do also have the computer system. What is angiocity and why is it used? By angiocity, we mean the vessels, especially arteries, with the CT method and the use of contrast media, allowing the study of the vascular system to identify some diseases such as aneurysm, dissection, and stenosis. The angiographic method is through the puncture of an artery to enter the vessels with special devices. For CT angiography, we only need to place a needle in a vein that we find on the arm of the patient, according to some protocols. Which are the techniques of acquisition in CT angiography? The angiocity is the examination in which vessels of the body are visualized by X-rays in order to be studied. How the patient should be prepared? Before the examination, the patient should not eat 4 to 6 hours before the examination. Yeah? And also the patient should bring the kidney test to see how the kidneys function, and the patient should also be aware to stop every medication that can clot the blood. Once arrived, the patient will talk to the medical radiologist. He will ask him some questions, and then after, the patient will have to sign the consent form. If the patient accepts to do the exam, we will proceed as follows. He will enter the examination room, and we will ask him information about the name and also the birth date. Okay, the patient will have to remove any metallic object that can appear as artifact in the image. And after, the nurse will insert the needle, and then we as radiologist technician, we will have to make the centrage. Let's say that we are studying the thoracic aorta. The centrage will be done on the jugular notch. And if we are studying the abdominal aorta, the centrage will be done on the xiphoid process. And then after making the centrage, we will have to go to the computer system, which is part of the CT scan. And then we'll select the name of the patient and then the type of exams that we want to do. And after, we will perform a scout that will allow us to really choose the exact place we want to send radiation. And then after this, we will have to take those so-called pre-contrast image. After taking the pre-contrast image, we will return to the scout, on which we will have to select where we want to do the arterial phase, venous phase, and final phase. And then after this, we will have to do the so-called smart prep, which allows us to see how the tissues, how the contrast media impregnate the tissue. And then after taking the scanning of the previous scan, we will have to do the smart prep, and then we will have to place the ROI, which is the region of interest, that allows us to study the density of the tissue on which we have placed it. And then we will have to send radiation, and then we will take the images that we call the post-contrast images. Okay, here's some images that show us how to place the arterial phase, and then venous phase, and also final phase. And in this graphic here, okay, in this graphic here that shows us a pre-contrast image and also a post-contrast image, and this graphic will show us how the contrast media will follow, will step into the body of the patient. Acquisition protocols. If we are studying the thoracic aorta, the amount of contrast volume is 125 millimeter. The injection rate is 3 millimeter per second. The row, which is the region of interest, will be placed on the aortic arc. The slice thickness for the image will be inferior or equal to 1 millimeter. The scan field will be placed on the apex of the chest below the diaphragm. If we are studying the abdominal aorta, the amount of contrast media will be 125 millimeter, and the injection rate will be 3 millimeter per second. The region of interest will be placed on the abdominal aorta, and the slice thickness will be 0.5 millimeter. The scan field will be above the diaphragm to the bifurcation of the internal and external iliac arteries. For the contrast media, the amount of contrast media depends on the concentration of the contrast and also on the weight of the patient. Here is a pre-contrast phase. Here is an after-contrast phase. Post-processing, this is an important step. The post-processing means any changes that we bring to the image that we have acquired. Between post-processing, we do have the so-called multiplanar reconstruction. That is the process by which we turn the axial image that we have, that the machine, the device has given to us, into coronal and sagittal, and so on. We do also have the MIP, which is the maximum intensity projection, that projects the voxels with the highest attenuation volume. And the last one in this case is the volume rendering that allows us to see the vessels in 3D. This is mandatory to do this type of reconstruction after studying vessels. To do this, we will use the portal phase with the lowest thickness. This is a thoracic aorta. This one is the ascending aorta that is affected by an aneurysm. This image is a volume rendering. And this one is a multiplanar reconstruction showing the thoracic aorta in an oblique view. This one is the abdominal aorta that is affected by aneurysm on 3D reconstruction. And here we do have the multiplanar reconstruction, the coronal view. This one is the patient after the treatment. My conclusion, thanks to the continuous evolution of TG systems, it is possible to perform scans of the internal course of the aorta up to the lower limbs in a few seconds, allowing a good evaluation of the vascular system in a non-invasive way. Fundamental for obtaining high-quality images, it also deals with the interaction with the patient, instructing for all phases of the exam. Getting the maximum collaboration is fundamental. It also optimizes the acquisition of the exam for the purposes of dosimetric rationalization of radiation. I would like to add in conclusion that it may seem easier to do as a job, but it is not so simple as you can think. Today, it represents one of the most important and most widespread techniques that require the radiologist technician experience, knowledge of the technology of tomographic system. This is why I conclude my cycle of studies by handing over this experience so that it can be useful for my future as radiologist technologist in combining technology. Clinical diagnostic needs the well-being of the person we will assist. Thank you so much.
Very good.
Thank you so
for the
much.
presentation. And allow me two short reflection and one question for you. First reflection, the argument, even if simple, was found to be fundamental to the mission that the university for the skill required of the technician. And the second reflection, I am sure that the candidate has acquired all the skills to execute the role of a technician with professionalism and combining personal aspects such as education, passion for the profession, duty and kidneys to offer to the person she will assist. And now a question, but more than anything else, a clarification for all present. In the exposition, we have only mentioned dose reduction. The technician has the task of optimizing the examination in this aspect. From your experience of these years, what can the technician do?
Okay, thank you so much for the question. The devices, the machines, they are equipped with the modulation and dose reduction system. This is based on on the density of the images, on the density of the patient, on the lateral scout that the X-ray will cross. And I think the radiologist technologist has a really important role in the compromise of having a good image and also by reducing the dose of the patient. Thank you so much.
The last students, the next students is, not last because there is Veglio, sorry. The next is Perrone, Martina, Dario, and with Dario we have done a work about the high field brain MRI spectroscopy, physical principle and the technique of execution. Spectroscopy with magnetic resonance technique is a non-invasive neurological study method of recent clinical application that allows to obtain in vivo metabolic and ultrastructural histological information of the tissues under examination. Yeah. We can start.
Buon pomeriggio a tutti. My name is Dario Perrone Martina. This is my thesis and talk about the high field brain MRI spectroscopy. The difference, the principal difference from the typical resonance, the principal difference between spectroscopy and the classical magnetic resonance is based on a single factor. To make our magnetic resonance spectroscopy, we take a traditional exam of resonance and decide a particular point of interest, volume of interest, and the dimension of this volume of interest must be 10 for 10 millimeters. To start, we must know the principal basic element. In fact, when the first element from what we start is a proton, we know if a proton is inside a magnetic field, it will follow the direction of the magnetic field. And in this case, we know the frequency, and this answer to the situation is explained by the equation of Larmor. How to explain radio frequency pulse? To explain radio frequency pulse, we must say that this pulse start from a point, and we can apply deviation with an angle of 90 or 108 degrees when arrives to the maximum frequency. We notice two situations. If the radio frequency pulse is activated, the hydrogen molecules will change their position and absorb the energy. But in the moment when we stop the radio frequency impulse, we notice a great difference, because in this case the hydrogen molecules return in their position and release the energy that they are acquired. The chemical shift, we know that the resonance properties of the nucleus of interest not only depends from the magnetic fields, but also by the chemical environment. For example, we can take the simple H2O, aqua. The hydrogen contained in them, when in the moment when we exposed to the magnetic field, we will notice a little difference in the molecules, because we applied a radio frequency that will change their position. And in this case, we can explain also from the Fourier transform. The Fourier tells us what when a signal arrives, what happens? Transform these signals into its little components, and the spectroscopic data that we achieved are positioned in dual dimensional graphs, in where on the axis we have the intensity, and the quantity is represented along the ordinate. The spectroscopy of the proton, we know that each metabolite is characterized by two time of relaxation that are of T1 and T2. But there is another important element that we must take in consideration, and this is it is the time echo. The time echo is essential, because if we chose a time echo that is superior to the 130 milliseconds, in the image that we create, we have the total disappearance of the metabolite along the short T2. Like the localization techniques, when to do this type of exam, we take a normal exam of resonance, take a VOI, volume of interest, and study this precise point that must be the 10 for 10 for 10 millimeters. Other techniques of localization are press and steam. Press, we know that the pulse sequence is applied to 90 grade less 108 grade and less 108 grade. But the stem, in contraposition, we notice that the pull sequence is at 90 grade, less 90 grade, and for the last, less 90 grade. These are some examples. We know that the multi-slice spectroscopic image is in particular very important, like ESAM, because we can study a particular function of the section that we selected. The difference, essentially the difference between why we consider the 3 Tesla, 3.0 Tesla better than 1.5. Essentially because the scan times are shorter, the T2 relaxation times are reduced, but in contraposition we know that this type of exam is not so present in a major type of hospital. Contraposition, because we know that this type of exam can give us major quantity, a large quantity of information from the classical resonance. Finito.
Okay, Dario, I think in this work we present the whole physical principle and technique. You compared the difference between high field magnetic and low magnetic resonance. I don't have any question because I know the time that you have spent for this work. Is unusual exam, the spectroscopy MRI. Okay. Thank you for the work and for the time.
Yes.
Okay, now is the last. Is Alessandro Maria Vegliò, and the work is about the Angiography dual energy for pulmonary embolism. The aim of this work is to demonstrate the effectiveness and the performing value of DECT for a correct diagnosis of pulmonary embolism. Okay.
Okay, thank you. Good evening, everyone. Today I will talk about the Angio-CT dual energy for the diagnosis of pulmonary embolism. In particular, in this paper I have analyzed the best techniques in use related to the pulmonary embolism, identifying the different algorithms to be followed in the case of a patient with the hemodynamic instability or stability before diagnostic assessment by CT, and subsequently how the dual energy has increased the ability to visualize occlusion due to pulmonary embolism and consequently the diagnostic result of this pathology. An acute pulmonary embolism is a closure of a pulmonary artery, most often due to a detached blood clot that embolizes the circulation. This blood clot is called embolus. PE is one of the major causes of morbidity and mortality worldwide because it's frequently misdiagnosticated and by this is one of the third most frequent cardiovascular disease. Okay. This obstruction of the pulmonary arteries creates a ventilation perfusion mismatch caused by the increase of the pulmonary vascular resistance due to the vascular occlusion. In the majority of the cases, the respiratory failures in the pulmonary embolism are a consequence of the hemodynamic disorders. The most common cause of this pathology is the deep vein thrombosis. That is a pathology that followed by a thrombosis of the lower limbs. Generally, the upper limbs are not involved. Okay. Moreover, for the diagnosis of the pulmonary embolism, we have to take in account many predisposing factors to try to achieve an early diagnosis and consequently a possible treatment. Here we have an example of a risk stratification score, in particular the Wells score, that is used to quantify the probability for the PA in patients in which the anamnesis and the examination suggest that the pathology is a diagnostic possibility. Okay. There are a variety of diagnostic tools used to assess the diagnosis of PE. Diagnostic tests such as D-dimer, echocardiography, and CTPA are used after the evaluation of clinical probability of PE incidence on the basis of the prognostic factor. For example, we have this example is the algorithm for the hemodynamic instability in patients with hemodynamic instability. The first step to follow is the echocardiography, because we have to check if the right ventricle of the patient is pumping correctly. So, and after we can proceed with the CT without risks. Otherwise, we have the algorithm for patients that do not have the hemodynamic instability. So in this case, the choice of the diagnostic method is focused on the probability that the patient has or not an high risk potential for the occurrence of the PE. Here, the patient, if has a lower intermediate clinical probability, have to do the D-dimer before the D-dimer testing before an eventual CT, because if we have a negative D-dimer with a low possibility that the PE may occur, we can exclude the pathology. Here we have an example of a computed tomography pulmonary angiography that can detect the right ventricular dilation, indicating the severe potentially fatal PE signs. A diagnostic CTPA should result in an adequate opacification of the pulmonary arteries, such that the thrombus can be readily distinguished from the intraluminal contrast material, as is seen in this picture with the red arrows. Okay, finally, we have the application of the dual energy. Compared to the conventional CT, the dual energy can provide information on both lung morphology and functional information in a contrast-enhanced exam. DECT can provide multiple unique images through 2 or 3 material decomposition processes that can distinguish tissues expressed as a linear combination of base material densities. For example, in the composition of the iodine, the soft tissue and air can be used to generate iodine maps and virtual no contrast images. The iodine maps highlights iodine-containing tissues, and the virtual no contrast image with the iodine-containing pixels removed simulate a real image with no contrast. Furthermore, we have the DECT can also generate the virtual monoenergetic images that simulate a single energy level X-ray beam and are obtained by linearly combining imaging with different aspect ratios. Here we have some examples of this kind of images. In the A is a conventional CT images without DECT. In the B, we have the iodine map,
In the picture C, we have the virtual no contrast image and the virtual monoenergetic image in picture D. Okay. As that is an evolving technique, there is no standard protocol for the diagnosis of this pathology. Generally, it is recommended to use 70 kilo electron volt images with the lower tube voltages to better intensify the small intraluminal clots. In the event that the injection of a contrast medium is required, it is recommended to use an highly concentrated iodinated agent, contrast medium, to distinguish iodine from other components. To inject the contrast medium, a region of interest, or ROI, is usually placed in the main pulmonary artery, and a bolus tracking method is used to follow the contrast flow. To assess blood pressure and lung parenchyma in a single scan, the delayed scan time should be longer, at least for 7 seconds, and the direction of scan should be the cranial direction to avoid streak artifact caused by the high concentration of the contrast medium. Here we have a variety of images from the normal images in upper left part of the picture, and so on at various level of kilo electron volt. This different attenuation at different energy levels can distinguish different tissues and material beyond conventional CT that is based solely on density. In this case, at low energy levels, the photoelectric effect is the main interaction depending on the atomic number. So the iodine is more intensified on respect on the normal image. Otherwise, at high energy levels, the Compton effect dominates and depends on the tissue density. So is useful to reduce beam hardening due to prostheses and arthroplasty or metallic materials. Okay, to conclude, the iodine map. To conclude, the iodine map is the most common used direct image in a pulmonary vascular assessment. It can provide the qualitative and quantitative information both on lung morphology and lung perfusion. The main advantage of DACT is that it can visualize pulmonary parenchymal perfusion defects caused by pulmonary arterial occlusion and allows direct visualization of filling defect in PA. In this paper, after examining all the diagnostic process of patients suspected of PA, the attention was focused on the importance that, since its discovery, the DACT has acquired in the diagnostic field. In this context, it was finally analyzed how the application of the dual energy to conventional CT has substantially increased and improved the diagnostic outcome for PE without applying an increase in the dose of radiation, in the dose of radiation and in the contrast medium, with a better differentiation of tissues that in the conventional CT would result with the same attenuation level or the same Hounsfield unit. Thank you.
Okay. Thank you, Alessandro. You had a good job.
Thanks.
I thank you not only for this work you had now, but for all the 3 years you spent in our hospital watching the exams and doing things.
Thank
you were you had a good job during the training.
Thanks.
I have a little question. You talked about the iodine maps.
Yes.
What is the limit beyond which we could have a error or of interpretation? What is the limit of the iodine map?
Okay. As I said before, the iodine map shows only the iodine containing contrast agent in the tissues. So do not show the true perfusion of the vessels, but the flowing of the contrast medium. So only for this reason, as it has to be read carefully, because sometimes, not always, the pulmonary embolism cause filling defect in pulmonary arteries, because sometimes there's the possibility that a small embolus go in the circulation but do not occlude the pulmonary artery, so we don't have the filling defect in the image, so we can fail the diagnosis. Thank you.
It's all, and please go out of the rooms, because there is the reunion of the commission, and after there is the proclamation. Okay, thank you.
So, first of all, welcome, and I would like to thank all the students for their work and for the discussion of their thesis. And I would like to say a special thank to Professor Santarelli for directing in a so special manner the students during these 3 years by hand. So it's time for the proclamation. So Mr. Jerry Jules came here, please. The committee, considering the curriculum of studies you completed and evaluated the practical exam and the degree dissertation attached to the final exam, the degree of 110 out of 110 cum laude. So, by the authority granted to me by the rector, I proclaim you registered in imaging and radiotherapy technique. Congratulations. Mr. Dave Delva, the committee, considering the curriculum of studies you completed and evaluated the practical exam and the degree dissertation attaches to the final exam, the grade of 110 out of 110 cum laude. Wait, Dave. By the authority granted to me by the rector, I proclaim you registered in imaging and radiotherapy technique. Congratulations. So, Mr. Dio Joseph Umpatin, the committee, considering the curriculum of studies you completed and evaluated the practical exam and the degree dissertation attached to the final exam, the degree of 107 out of 110. By the authority granted to me by the rector, I proclaim you registered in imaging and radiotherapy technique. Congratulations. Mrs. Deniette Ledoux, please. The committee, considering the curriculum of studies you completed and evaluated the practical exam and the degree dissertation, attaches the final exam degree of 110 out of 110 cum laude. By the authority granted to me by the rector, I proclaim you registered in imaging and radiotherapy technique. Congratulations. Mr. Dario Perrone Martina, the committee, considering the curriculum studies you completed and evaluated the practical exam and the degree dissertation attached to the final exam, the grade of 98 out 110. By the authority granted to me by the rector, I proclaim you registered in imaging and radiotherapy technique. Congratulations. Mr. Alessandro Maria Vegliò, the committee, considering the curriculum of studies you completed and evaluated the practical exam and the degree dissertation attached to the final exam, the degree of 110 out of 110 cum laude. By the authority granted to me by the rector, I proclaim you registered in imaging and radiotherapy technique. Congratulations. Congratulations to all students. So now we choose one of you students for,
Yes.
if you want.
For Ledoux, yes, please read the.
Mrs. Ledoux.
Okay, thank you so much. I swear by Apollo Healer, by Asclepius, by Aegea, by Panacea, and by all the gods and goddesses, making them my witnesses, that I will carry out, according to my ability and judgment, this half and this indenture, to hold my teacher in this heart equal to my own parents, to make him partner in my livelihood when he is in need of money, to share mine with him, to consider his family as my own brothers, and to teach them this art, if they want to learn it without fee or in danger, to impart precept, oral instruction, and all other instruction to my own sons, the sons of my teacher, and to indentured pupils who have taken the healer's oath, but to nobody else. I will use those dietary regimens which will benefit my patients according to my greatest ability and judgment. I will do no harm or injustice to them. Neither will I administer a poison to anybody when has to do so, nor will I subject such a course. Similarly, I will not give to a woman a pessary to cause abortion, but I will keep pure and holy both my life and my heart. I will not use the knife, not even verily on sufferers from stone, but I will give place to such a craftsmen therein. Into whatsoever houses I enter, I will enter to help the sick. I will abstain from all intentional wrongdoing and harm, especially from abusing the bodies of men or women, bond or free, and whatsoever I shall see or hear in the course of my profession, as well as outside my profession, in my intercourse with men, if it be what should not be published abroad, I will never divulge, holding such things to be holy secrets. Now, if I carry out this oath and break it not, may I gain forever reputation among all men for my life and for my heart. But if I break it and forswear myself, may the opposite befall me. Thank you so much.
Okay, it's all. It's finished. Thank you for all for the participation. Okay. Thank you.